This is Rahil Jummani. I'm Clinical Assistant Professor at the NYU Child Study Center. Welcome to our webinar series. Today I will discuss Medication Demystified, the ins and outs when considering medication for your child. You can submit questions at any time today by typing them into the questions pane of the control panel that's on the right side of your screen. We will answer questions at the end of our presentation. As many as 10 to 20% of all children have a medication-responsive psychiatric disorder. That's millions of youth in our country. Research shows that the majority of major emotional and behavioral disorders in adults actually start in childhood or adolescence. Psychiatric disorders certainly have a detrimental impact on social, emotional, behavioral, and academic functioning and development. Some disorders cause progressive impairment if left untreated, conditions such as schizophrenia, bipolar disorder, but also other conditions that are fairly common, such as ADHD, anxiety, depression. These disorders all have an impact on a child's self-esteem and their ability to progress. So it's critically important to understand them early on and target with treatment. There is scientific evidence that early and effective intervention can alter the developmental trajectory of a child in a positive direction when they're suffering from a psychiatric condition. Conditions that respond to medication include attention deficit hyperactivity disorder, also known as ADHD, the various anxiety disorders, including generalized anxiety disorder, social anxiety disorder, obsessive compulsive disorder, separation anxiety disorder, panic disorder, selective mutism, and post-traumatic stress disorder, or PTSD. Other conditions that also respond to medication intervention include depression, bipolar disorder, schizophrenia, tics and Tourette's disorder. And while not a disorder, certainly when a child is highly aggressive or agitated, this may be an indication for medication use as well. Keep in mind that these disorders may respond to other modalities of treatment as well. Medication is certainly not the only recommended treatment for these conditions, but it may be an important and vital component of the overall treatment. So how does a doctor determine what medication to use? Children and adolescents must have a complete, a thorough, a comprehensive evaluation before psychiatric medications are prescribed. This is essential. What does this involve? It involves an interview with caregivers, an interview and observation of the child or adolescent who is presenting for care, conversation with other professionals who may have been involved with the caregiver, the family, the child in the past, including pediatricians. Also, folks at school. So teachers are critically important informants about the functioning of a child, the distress a child is experiencing as well. A review of medical records may be important, and again, collaboration with the child's or adolescent's pediatrician is important. Questionnaires may also be used. These are essential for gathering important information about a child's symptoms and their struggles early on while during the initial assessment, but questionnaires also play a role in ongoing care and treatment and can be used to monitor how well a child is responding to the intervention, medication, and or other treatment being used. What is asked of parents during the evaluation? What does a mental health clinician want to know? Most importantly, we want to know the reason for the assessment, the major concerns that the caregiver has, the family has about a particular child or adolescent. And we will ask probing questions to really have as full a grasp of the details as possible. Any prior mental health history is also critically important to understand. And so clinicians will ask about prior psychiatric problems and any treatments that have been pursued, including prior medication trials, different therapy modalities, if hospitalization was ever employed. All of these are important pieces of information. In addition, clinicians during the initial assessment will obtain a medical history, a surgical history, a list of any medication allergies or other allergies a child or adolescent may have, and a list of current medications that are being used, their doses, and how these medications were arrived at. The family psychiatric history is also important information to obtain. It tells us about potential familial and genetic risks that a child may have, and puts clinicians on the alert for things to potentially think about as a child's symptoms may evolve over time. It can also be an indicator of effective treatment. A therapy or medication that has worked for another family member may have a good shot of working for the child or adolescent that is being assessed. So it's important to obtain this information. A child's developmental history is critical. Mental health conditions have a profound impact on a child's development, and the child's stage of development impacts the way their symptoms present and may also impact the treatment that is employed. So getting a comprehensive developmental history is extremely helpful. A child's academic history to understand their functioning at school and how impactful their disorder has been on their scholastic achievement is important, as is a sense of a child's social functioning. These are two of the most important aspects of a young child's life, or for that matter of an adolescent's life as well, is their ability to function in school and their ability to engage in friendships and enjoy a healthy social life. So understanding how this is impacted by their symptoms, their condition, is important to ascertain, and the family functioning in general, and any concerns about how the child is functioning in their family is important to assess initially. Parents and adults, caregivers are able to share a lot of this information with clinicians, but what happens when the child or adolescent meets with the psychiatrist or prescribing clinician? With a young child, I or another doctor may engage primarily in play. So a child who is 6, 7, younger, they may be able to answer a few limited questions, but I will spend a lot of my time with them observing their behavior and engaging them in play to see how they respond to me, how they react to me, and what their choice of play is. That gives me a lot of information. And I may choose to do this with the parent in the room. They may be too anxious to have the parent step out of the room, and I want to watch the dynamic between the caregiver and the child as well. With an older child or adolescent, certainly a child who is 10 or older, sometimes children as young as 8, the session may be spent primarily asking the child what their thoughts are about the need for the assessment, to get their perspective on the problem, and have them articulate their concerns, not only about what brings them to the office, but about the assessment itself. Children and adolescents are often concerned about what doctors are thinking, what our intentions are, and having an open conversation about this early on can really help develop a strong therapeutic alliance. The comprehensive assessment is critical to understand the diagnosis and symptoms that must be treated. I can't emphasize that enough. And this is especially true in the field of mental health because there are no gold standard tests. There are no blood tests or brain scans that are diagnostic. And so doing a thorough assessment is the only way to truly understand how a child is suffering, their underlying diagnoses, and the symptoms that must be targeted in treatment. So once a psychiatrist has a clear understanding of the problem and determines the diagnosis and the target symptoms to treat, medication may be an option. And I can't say this enough. Medication is not necessarily the option, and it may not be the only option. In fact, many times, many disorders in the arena of mental health care involve a combination of medication as well as many other treatment interventions, including therapy, including collaborating with families and collaborating with schools and providing interventions in the academic setting. Once it has been agreed that medication is necessary, a clinician will discuss the following with a family: the different medication options and the pros and cons, the benefits as well as the potential side effects of the choices that are available, the details of how a medication will be administered, and what would be tolerable for a child. Would the child prefer a liquid form, a tablet, or are we best using a patch when available? So these are important considerations to make treatment successful. The anticipated length of treatment is also important to discuss, as well as any anticipated preliminary tests. There are some medications that have certain side effects that require monitoring by obtaining lab tests, and baseline values may be essential before medication is begun. Last but not least, it is also critically important for there to be an emergency plan in place. So if a child is having any acute, urgent, emergent symptoms that require the family reach the prescribing clinician, or if unfortunately there is any kind of concerning medication side effect, an allergic reaction, it is vital for the family to understand, for caregivers to understand how to reach the clinician in the case of an emergency, and often having more than one way to contact the clinician is important. And secondarily, if the clinician can't be reached, what the backup plan is. So I think it's important to clearly delineate this contingency, this emergency plan. Remember, the goal is to find the best possible treatment with the least possible risk. That comes from a thorough and complete understanding of the child's difficulties and what the best medications are that have been shown through research to be highly effective for the treatment, and to think about ways to mitigate potential side effects. It is critical that doctors and families work together to find the right therapeutic dose of medication for a child or adolescent, and this doesn't happen overnight. Often the starting dose is not the therapeutic dose, and adjustments are likely going to be required over time. Some medications take weeks at the right dose for optimal results to be seen. Planned communication between appointments is critical. Some prescribing clinicians are the therapist as well as the prescriber for a child. Other clinicians might only be the prescribing clinician, and the therapy may be done by another practitioner. In those cases, it's highly unlikely that the child or family is seeing the doctor on a weekly basis. Even more important that there be planned communication in between appointments, so medication doses can be adjusted in real time, so the child really achieves the maximal benefits as soon as possible. Now, families often ask about the dosing of medication, and sometimes believe that a child's dose ought to be a lot lower than an adult's dose simply because they are much younger or weigh a lot less than an adult counterpart. That being said, it's extremely important to keep in mind that children and adolescents, certainly children more so than adolescents, have a greater metabolic capacity than adults, and often much more rapidly eliminate medications. The younger the child, the much more potential for rapid metabolism. So again, you can understand why weight alone or age alone is not a sufficient guide for dosing medication. The best indication of the need to adjust the dose is a child's response to medication. Is it working? Are there side effects? And if there are side effects, are the side effects related to dose, and do they indicate that the child is being potentially overdosed? If the medication is not working, is it because the medication has not been given enough time to work optimally, or are we underdosing the child? These are extremely important conditions and discussions to be had in an ongoing capacity with the family and the prescribing clinician. Remember, every child's situation is unique, and a trial and error process is almost inevitable and often necessary to optimize treatment. Parents are often concerned about their children being used as guinea pigs. This is certainly not the intention of providers at all. The intention is truly to understand a child's unique situation and to optimize treatment, and this does require time. When you're extremely lucky, you get the right medication and find the right dose very quickly. Sometimes it's a process. Almost always a combination of therapy and medication is warranted. I can't stress that enough. There are sometimes conditions that will respond to simply medication, and therapy may not be indicated, but for many conditions in our field, the combination of medication and therapy is critical. Some children require more frequent dosing of medication than those that are older due to their rapid metabolism, and sometimes children require higher doses than you may anticipate, also because of their faster metabolism. By about age 15 years, an individual's metabolism is more like that of an adult, and that's when we find that adolescents require more adult dosing than they might have. And in fact, a child's dose may need to be adjusted over time for this reason. During the course of treatment, the doctor will perform other important activities. Doctors will monitor the child or adolescent symptoms and the effectiveness of the medications being used, provide ongoing support and education, assess the need for other interventions, including therapy, academic, and social interventions. So given this background of how a clinician assesses a child and makes a determination about medication, and how that medication is then pursued in an ongoing way as a cornerstone of comprehensive treatment, let's now look at some specific conditions and research-based medication interventions for them. The first condition that I'll bring to your attention is attention deficit hyperactivity disorder, also known as ADHD. Stimulants are actually the most effective treatment for all the core symptoms of ADHD, which include inattention, hyperactivity, and impulsivity. Stimulants consist of two families, and both work primarily by increasing levels of a chemical in the brain called dopamine, and secondarily by also increasing another neurochemical known as norepinephrine. Those two families are the methylphenidate family and the amphetamine family. The active ingredient in each of these families is exactly the same for each member of the family. So every medication in the methylphenidate family has the same active ingredient, methylphenidate. And every member of the amphetamine family has the same active ingredient, amphetamine. There are individual differences between medications, and those differences are primarily due to manufacturers attempting to create medications that last for different amounts of time. So for example, one methylphenidate medication, known as Ritalin, lasts about 3 to 4 hours. Another medication that has the same active ingredient, methylphenidate, Concerta, lasts up to 12 hours. And these medications are specifically created in the laboratory to last for different lengths of time. Now, the side effects of all the medications are similar in the stimulant category, including decreased appetite, insomnia, headache, stomach upset, and the potential for mildly increased heart rate and blood pressure, which is completely benign if a child has no history of heart disease. It is critically important for a clinician to ask families about a child's history of cardiac problems, especially structural heart defects, and potentially that in the family as well. Some may ask about tics. There's no contraindication to using stimulants when a child has tics or Tourette's disorder. It does require additional monitoring and conversation with families about the potential for tics being exacerbated. Current research does show us that in some children, tics are actually reduced on stimulant medication. So this is an important conversation to be had. Again, agents in the methylphenidate family include such medications as Ritalin and Concerta. Individual drugs in the amphetamine family that you may have heard of include Adderall, Adderall XR, and 5-ANS. There are also non-stimulant medications to treat ADHD. These include medications in the alpha agonist family. Medications you may have heard of include Intuniv and Capve in this category. Other medications that are sometimes used to treat ADHD are Strattera, Wellbutrin, Provigil. When might a clinician prescribe non-stimulants? The non-stimulants are prescribed when some patients are unable to take stimulant medication. So for example, if a child had an underlying cardiac defect, a heart defect, a structural problem of the heart, stimulants may not be able to be used for that child, and so a non-stimulant would be considered. For some children, the side effects of stimulants are too significant and can't be used, and so non-stimulants may be chosen for those children as well. Finally, there are some children that may actually require a combination of stimulants and non-stimulant medications because their ADHD symptoms are so severe. That is another use of non-stimulant medication. Moving on from ADHD, I want to discuss two disorders that are treated by the same first-line agents. These are the anxiety disorders as well as depression. The safest and most effective medications for many of the anxiety disorders and for depression are first and foremost the selective serotonin reuptake inhibitors, or SSRIs, and also the serotonin norepinephrine reuptake inhibitors, or SNRIs. These medications are commonly called antidepressants, but as I just mentioned, they are effective for the treatment of anxiety disorders as well as depression. The SSRIs include many agents with which you may be familiar: Prozac, Paxil, Zoloft, Luvox, Celexa, Lexapro. The SNRIs include medications such as Effexor, Cymbalta, and Pristiq. The mechanism for the SSRIs is to primarily increase a chemical in the brain known as serotonin. The SNRIs increase both serotonin and norepinephrine. Common side effects of these agents include headache, stomach upset, nausea, appetite or weight change, as well as sleep changes. Some of you may be wondering about the black box on these agents. When these agents are initiated, especially for the treatment of depression, there has been shown to be a mild increase in suicidal thoughts in children and adolescents. There has been no study that has shown that a child has taken these medications and gone on to successfully complete suicide. And we do know that the overall outcomes for children with depression and anxiety disorders, once they have been on these medications for an extended time period, is that the risk of suicide actually decreases well below baseline levels before treatment was initiated. The period of risk that requires close monitoring by caregivers and doctors is the first 10 days to the first month of starting the medication or changing the dose. It does take a few weeks and titration of doses to see therapeutic benefits. The medication must be taken daily to achieve therapeutic levels. To discontinue, the medication must be slowly tapered over time as well. Bipolar disorder is another important condition that is responsive to medication. The medications we use to treat bipolar disorder are collectively known as the mood stabilizers. They consist of medications used to treat epilepsy and seizures, the antiepileptics. They also consist of medications known as neuroleptics or antipsychotics. And lastly, the mood stabilizer family includes lithium. In adults, many of these agents have been shown to be equally effective. In adolescents, the neuroleptic category appears to be more effective than either the antiepileptics or lithium. The neuroleptics are also called antipsychotics because they treat psychosis and schizophrenia as well as bipolar disorder. Older agents are called the first generation or typical neuroleptics, and the newer agents that have been shown to be highly effective in adolescents with bipolar are called second generation or atypical neuroleptics. Side effects of these medications include the possibility of abnormal movements, increase in certain hormone levels such as prolactin, and the serious concern about weight gain and insulin resistance that must be carefully monitored and discussed with families. The atypical neuroleptics include agents with which you may be familiar, including Abilify and Risperdal. The antiepileptics are also effective for the treatment of bipolar disorder, and as I mentioned earlier, are also used to treat seizures and epilepsy. Potential side effects of these agents include tremor and impact on liver function, and rarely reduced platelet and white blood cell counts. So again, careful monitoring and blood tests are required when using these agents. Antiepileptic medications that are used to treat bipolar disorder include Depakote, Lamictal, Tegretol, Trileptal, and Topamax. Finally, lithium is an effective treatment for bipolar disorder. It has a novel mechanism for the treatment of the condition that may involve stabilizing brain cell membranes. Kidney and thyroid function needs to be monitored because the side effects of lithium include an impact on kidney and thyroid functioning. Other side effects include acne and tremor. Keep in mind that lithium is a natural treatment found in the periodic table of elements. Tics and Tourette's disorder is another important condition that we sometimes use medication to treat, but keep in mind that the first-line treatment is therapy, a type of treatment called comprehensive behavioral intervention for tics, or CBIT. Medications are used for moderate to severe tics that don't respond to therapy alone, or when therapy is not an option. First-line agents include, again, the alpha agonists that I mentioned earlier as potential non-stimulant treatment for ADHD, and children with a combination of tics and ADHD, in fact, respond best to the alpha agonists for treatment of their tics. Second-line agents include the neuroleptics, such as Abilify and Risperdal, that again we also use to treat schizophrenia and bipolar disorder. The last area that I want to cover is that of aggression. While not a disorder, it is something that many families struggle with when a child is suffering from a mental illness. Keep in mind that the most important strategy is to understand the underlying diagnosis and symptoms leading to aggression and treating those disorders and the symptoms effectively. For example, a highly anxious child may be agitated and aggressive, and the most important intervention there will be to treat that child's underlying anxiety. Behavioral and environmental interventions are critical, including at home and at school, and then medication specifically should be considered. In autism specifically, 2 of the second generation or atypical neuroleptics have been FDA approved for the treatment of aggression and agitation. These are Risperdal and Abilify. I'm ready for your questions now. So the first question is, what should I do if I notice my child's medication, fluoxetine, is causing side effects such as depressive behavior or negative mood swings? So the first strategy would be to really contact the child's prescribing clinician. It's very important to have a clear understanding of the timeline, when the new symptoms emerged, how effectively the fluoxetine was treating your child's depression prior to this change that you noticed. There may be a lot of reasons for what you're seeing. It's possible that the medication has not been adequately titrated to the dose that will actually be optimally responsive, or that the brain has actually adjusted to long-term use of this medication. So having this discussion with your child's prescribing clinician, having a clear sense of the timeline and the emergence of symptoms, thinking about what other side effects might be present. If there are many other side effects, it may simply mean that it's time to move on and try a different medication. If there are no other side effects, it may actually be pointing to the medication being inadequately dosed and needing to be adjusted, either because the actual therapeutic dose has not been reached, or that there has been an adjustment process in the brain to the impact of the medication, or because the disorder itself has changed a bit and the treatment needs to be rethought. I can take another question. So the next question we have is, what should I do if I notice my child's medication? So the next question we have is, stimulant treatments for ADHD. What risks are there for children taking them for many years? Are there studies that show these results? That's a great question. So one risk that has been talked about for some time is the risk of negatively impacting a child's growth. Initial studies led to a lot of concern in the field about this. What we do know now is that when a child starts taking stimulants, the period of impact on growth seems to be the initial few years, and in fact, over time, levels off. We also know that children who are given drug holidays from stimulants, so children who don't take stimulants on weekends, holidays, aren't likely to have any impact on their growth. Furthermore, we know that it's critical to make sure that a child's nutritional intake is monitored. Keep in mind that appetite suppression is a well-known side effect of the stimulant medication, and the long-term issue around growth is very much related to this issue of appetite suppression and decreased intake. So perhaps working with a nutritionist can also mitigate this. And we often have conversations in the office about nutritional management and optimizing caloric intake to, again, mitigate the impact on growth. Again, at this point, the more recent studies indicate that adults who've been in treatment for ADHD typically are their expected height, especially when nutrition has been taken into consideration during treatment and when drug holidays have been used. The other long-term side effect that I'll mention is that some individuals find that with long-term use of stimulants, their positive therapeutic impact seems to diminish. That is something to also sort of have an ongoing conversation with a prescribing clinician about, and why it's important to always use the lowest dose that's impactful. So if additional changes need to be made, increases made over time, it's not from too high of a dose. I'll take one more question. the question that I'll end with is medication the last resort? If therapy is working fairly well, should a parent explore using medication? So I would reframe that question and say that medication is not necessarily a last resort. We have excellent research data to suggest that for some disorders, medication is a critically important, essential, and necessary piece of the treatment. For other disorders, such as, let's say, mild anxiety or depression, therapy, when available, would be the first-line treatment and may be the optimal treatment, and medication may be entirely unnecessary. However, for moderate to severe depression, medication may be a critically important piece of the treatment as well. So medication is not necessarily a last resort. In some cases, therapy and other interventions are sufficient. In other situations, medication is a critically important piece of the treatment. One example would be attention deficit hyperactivity disorder, where medication addresses all the core symptoms of ADHD in a way that many therapeutic modalities are unable to. With that, I will say, on behalf of the Child Study Center, thank you for joining me today. Once we leave the webinar, you will receive a survey, and we would appreciate if you would complete it. You will also receive a follow-up email within a day or two with a link to recording of today's presentation. We hope you can join us for the next webinar, I Think, Therefore I Can't, Helping Your Child Build Resiliency and Grit with Paul Sullivan, MS. That's on Tuesday, June 27th at 1 p.m. Thanks again. Goodbye.